Thank you, Kenneth, for the wonderful presentation once again. I take this opportunity to thank you, Thrice, for the contribution, and hopefully in the near future, not so near future, we'll do it again in Hong Kong, my friend.
Excellent.
So take care and stay safe. Okay, as I mentioned, just to let the other speakers go away, it's a weekend. So if any of you have any questions, please put them on your chat. Oh, sorry, Rossini, you're here. So can you please, are there any questions for the speakers so far, Jamie and Kenneth?
So we've got some questions here. So we've got some questions for Dr. Barata about ultrasound guided neuroaxial for morbid obesity patients. So we've got a questions from Dr. Sandeep Matha from India. So they're just wondering why you have better sonal images in patients with high BMI than in lower BMI, because I think it's not very much as expected.
It wasn't. That was a unique patient. It was a younger patient, and it was just kind of the distribution of the adipose. I think we got lucky, honestly. In most cases, the larger the BMI. And I've also found, in going with, what as we would expect, the changes as patients get older, the older patients will be more difficult imaging. So I think it was just a younger patient. And that's why I always say, just because they're super morbidly obese, it doesn't mean you're not going to get good information.
Okay, thank you. So we've got another question from the same participant. Any experience on post-bariatric surgery patients, because their subcutaneous fat is reduced and the stabilization of landmark would be more difficult?
So, I mean, that's what's important really with any obese patient, but especially in the bariatric patient, because they're going to have a lot more loose skin. So that's, marking can be difficult. So it may come down to, really anchoring, that area to make sure that you're not getting lost when the skin moves. So it can be more difficult, and that, because of all that skin movement, to kind of lose your place. But it still can be done. And again, it can still give you, valuable information.
Okay, thank you. So another question, I think for all speakers, you can probably answer this one. So how accurate is ultrasound identification of vertebral level compared to the gold standard using X-ray and CT?
Oh, when you look at ultrasonography, it's not 100%. The published data indicates that you can accurately locate a given intervertebral space in about 70 to 80%. This is better than 30% when you look at your landmark base. So there are different reasons why you're not 100% accurate. These are validated with correlative CT imaging. Is that you may have lumbarization or sacralization, because L5S1 is often used as the starting point from where you start your count up. So, and even if you use the 12th rib, which is rarely used, there can be anatomical variation. So I think you can never be 100% correct. So this is my answer to your question.
Okay. Another question from Dr. Joan Carlos Sosa. Again, I think this can be answered by all the speakers. How to identify osteophytes or any other alterations that will warn you to stay away from a certain scan space?
When you do an ultrasound imaging, if you see alteration in the normal anatomical pattern, like for instance, if you're looking for an interspinous view, and I'm not saying that it's a narrowed interspinous, but you're looking for the articular pillars and the transverse processes with the typical the spinal canal producing the cat's head-like appearance. You will find that often osteophytes, if they are related to the articular processes or they are, facet joint related, then sometimes you may see that you can only see half of the posterior complex, or even part of the posterior, the dural sac. And this is a telltale sign that they may be osteophytes or something producing acoustic shadows. Now, it could be ossification in the interspinous ligament too, but generally, I find that this is something that appears in the ultrasound image, and whenever you insert a needle where there is the shadow that produces the acoustic shadow, you will often strike bone. So these are not well described, but I think with experience you will find that these are some telltale signs. I don't know if anything more you can add to that, Kenneth?
Yeah, I agree with you, Manoj, completely. These areas of calcification can be very small or can be very big. The big ones, I think, will block your view completely. And if you look at the images that I showed you, the ones that are relevant to us are the calcifications within the supraspinous and the interspinous ligaments, because those can really get in the way of the acoustic window. Now, when you're doing a real-time ultrasound, you're really looking out for a safe space to inject. So assuming, number one, you don't have any pre-procedural imaging, which is rare in these days within the hospital setting, then as you're looking for that space, you get a sense that, number one, the anatomy is not right, and number two, you can't find the spaces that you're trying to identify, and that's already a warning sign one. And that's why, as Dr. Carvalho said, even with routine cases, you want to at least place an ultrasound probe and build up your database of what normal should look like. And once you have that database of normal in your mind, when you encounter a problem, you get a sense that this is not right. Now, the other thing I wanted to add was that the difficulty of numbering the spinous levels. Spine surgeons have been known sometimes to perform surgery at the wrong level, and wrong level surgery is a big litigious issue, especially in certain jurisdictions. And one of the ideas that has been floated is the use of fiducials. So implantable fiducials. For example, radiology department can insert for you certain markers, even certain clips at certain levels in the thoracic spine, for example. And when you're doing a fluoroscopic injection, you see the marker, and then you know that it's at that level. For ultrasound, I think it may be a good idea to at least develop or have a similar implantable fiducial that you can mark out at the tip of a spinous process, for example, or even the transverse process. This will then allow easier or more reliable repetitive identification of that level. So if you have to go into that space again, at least you have a level identifier, number one. Number two, whenever you infiltrate that particular area with local anesthetic before you insert your spinal needle, for example, that can also, if you get a bit of air into that syringe, that can really distort the ultrasound image as well. And so if you have a bright, shining fiducial implanted within that level, you can go back and identify it with some reliability. So that's an idea for us to consider.
Yeah, that's a good thought, Kenneth. Any other questions, Rossini?
I have a question myself for Dr. Shia. So just wondering, for the epidural lipomatosis, are we able to visualize them on ultrasound images so that we can predict the efficacy or the limitations of our procedure before we perform it?
It's a good question. Now, if you recall the images that we have, let's take L5S1, for example, because that's a nice, reliable level that we can use. L5S1, luckily, doesn't have very much epidural fat. It's got enough. So you can identify the ligamentum flavum, and then deep to that, if you are able to see down to the cauda equina nerve roots, that's great, because then that tells you that there's nothing attenuating the ultrasound beam. But I find that it's difficult sometimes because it's a narrow space as well. Fat is usually bright on ultrasound in that space, So if you can't identify the cauda-equina nerve roots as clearly as you normally would, move your probe to the other side and compare as well. Again, a high index of suspicion is sometimes required. The usual distribution of epidural lipomatosis is somewhere in the thoracic spine and the upper lumbar spine. Those are the usual areas. So the L5-S1 space, as Manoj has said, is usually quite a safe space to enter. But apart from that, I really don't have that much knowledge, actually, if you can really identify it if you're higher up in the thoracic spine.
All right, thank you.
Manoj, any ideas?
No, man, I wouldn't know, because I think if you just see the patient for an intervention without following up the patients previously, it may not be possible to just say that this is a wider epidural space, because the width of the epidural space, I find, is quite variable.
Yes,
even from patient to patient, or from individual to individual. So, although there are some normograms with the width of the epidural space, but I don't think this would be possible to say that this patient has epidural lipomatosis. But I would think this. I was just thinking while you were speaking, is that if you place an epidural and your patient had epidural lipomatosis, then maybe it's conceivable that it may affect the efficacy of the block,
Yes, it will. Yeah.
In some way, yeah. That's
right. And also the other problem, Rossini, is that you will have loss of resistance anyway, because once you're through the ligamentum flavum, the fat doesn't produce very much resistance. So that can be a confounding problem.
Okay. All right. Thank you. We've got another question for Dr. Barata from Dr. Lee Lin from Melbourne, Australia. Would you consider MTP as an alternative for perivertebral block and ESP in morbid obese patients for mastectomy?
Yeah, so I think you have to always think about your options, because if if your standard is perivertebral, but if you go and scan and you really just can't identify the structures in the morbidly obese patient, it's important to know what other blocks you can do. MTP is a good option. I mean, there's not a ton of literature out there, but it does appear to, be a, novel fascial plane block that shows some good evidence. I tend to probably the one that I'm, in general, usually going to use if I can't see the perivertebral space clearly and, don't want to take, don't feel comfortable because it would be risky for complications. I usually go to the erector spinae plane block, but it's really what you're practicing most and what you're most comfortable with of those different types of blocks. So I think, again, it's important to keep all those tools in your toolbox and go through an algorithm if something's not working.
Okay, thank you. We've got all my questions, but I think this can be answered at a later part of our symposium today, because so there's an anonymous attendee that's asking whether you have any tips for imaging patients with post-vertebral surgery, for example, laminectomy. But I believe we have a talk later on by Professor Kamaka that talks about instrumented bags, so I think we can discuss that a bit later.
Yep, we'll talk about some of these aspects after the break.
Yep. So I think that's pretty much most of the questions that were asked.
Okay, I take this opportunity to thank Jamie. It's early in the morning, maybe breakfast time for you. And Kenneth again for joining in. And it's been a great session and for sharing your wisdom and experience. For those of you who logged in, I would like you to have your favorite beverage and get ready for the next session, because it's going to be quite riveting. And I hope you have a clear mind, because it's going to be an exciting session, and I have put together something interesting for you. So don't go away. You don't have to ring the bell or punch this or that. Just go have your favorite beverage and come back in 15 minutes time. Okay, we'll join you again in 15 minutes time. Thank you.